in field evaluation. With that, we move on to our next speaker, that's Dr. Parthopratim Majumder. And he's going to tell us about the evaluation of a patient with uveitis. So all to you, Dr. Partho.
Thanks. Can I have a slide? So, good afternoon, friends. So, I'll be talking to you on evaluation of a case of uveitis. So, when we think about evaluating a patient of uveitis, we are primarily we can divide it into three categories. Like in first, we just try to evaluate the anterior segment. We have slit lamp. Then, as you, I think Shweta has showed you how to do a gonioscopy, and you need to do check the intraocular pressure also. So, in second category, we just shift to the posterior segment, where we try to see that what is there in fundus, what is the clinical fundus looks like, and then we take help of various imaging techniques. And then broadly, because we are ophthalmologists, we have a different set kind of OPD. So we try to evaluate the various system, but here we try to take the help of history. We try to take various kind of history and try to see that whether the other systems are involved or not. Now, when we read our textbook and we have a conception that the patient comes to us, we take a history and then starts doing the clinical examination, then go to imaging, then we order laboratory investigations, and then finally we advise the patient treatment. But it's not the case. So what ideally we should do, we should greet our patient, just ask about the symptomatology, what are the presenting symptoms, then we do a clinical examination, and then we should start taking the history based on the clinical examination. Then we can do imaging, and if there is any relevant findings we can notice, then again we should revisit our history. And then we do a laboratory investigation, and then again the history is not over, then again we should take the history, and then finally we give the patient treatment. So, and all this should be done taking care of that systemic examination, which I'll be discussing in later slides. So now I always tell that the microscopy remains the mainstay in uveitis management. So no, not this microscope. I'm talking about this microscope, which we are the unique person in medicine who can see the inflammatory cells, who can visualize the inflammation under microscope, and we can categorize the inflammation. Think about the rheumatologists, they can't think about inflammation, they can't see inflammation. For them, if they want to see the inflammation, they need to do a biopsy, send that biopsy specimen to a pathologist, and who will tell them that whether there is inflammation or not. But unlike rheumatologists, we ophthalmologists, we can examine a patient, we can see the inflammatory cells, like we can see a lymphocyte, we can see a macrophage, and we can decide that how much is the inflammation. So just try to use this microscope. And when you start evaluating a patient, always try to decode the inflammation by dividing broadly into granulomatous and non-granulomatous uveitis. So all of you know that this classification is very ancient classification, also known as Wood's classification. The downside of this classification is that sometimes some entity, for example, the ocular sarcoidosis, it can start with granulomatous uveitis and again can present with non-granulomatous. But for beginning, this is the ideal classification to categorize the inflammation, and you can actually decide on your further course of action based on this classification. Now, as a postgraduate student, when you examine a patient in slit lamp in your outpatient department, then three things I want to highlight. One, the number one is rheostat. So sometimes what happens, you turn the rheostat very bright, thinking that you want to see the patient properly, and the patient is extremely photophobic and patient can't tolerate that. So immediately you turn down your rheostat, so your illumination comes down. Now here what happens, if there is 3+ cells, you will never miss it. You will try to, eventually you will find that there is 3+ inflammation there. But if it is a 1+ cells or occasional cells, then you may miss this clinical picture. Because if your rheostat is down, then you may not see it properly. And you have to do this because the patient is photophobic, so you can't turn your rheostat up. So what you should do here, instead of using a broad slit lamp beam which will cause the patient photophobia, you should reduce the width of the beam and use a narrow slit beam with full intensity of light. remember, you should not reduce the intensity of the light, rather the width of the beam. So that's how the patient, you can avoid the photophobia, and you can examine the patient and avoid missing the 1+ cells. Now the second problem you face in your clinic is that, is it a pigment or cells? Because when we use phenylephrine, the phenylephrine is notorious to cause pigment release from the iris, and sometimes this iris may give you an impression that you are dealing with a case of anterior uveitis. But if you see there, the inflammatory cells are relatively large, and the interparticle distance between them is more. And whereas if you see the pigments, they are brown, dark brown in color, and they are very sparse, very closely arranged, and the density will be much more than the inflammatory cells. Now, another important point I just want to highlight here is that the dilatation. So now you have to remember that always examine the patient before dilatation, because certain feature, for example, iris nodules, the pattern of the iris, and the before gonioscopy also you have to do. Now the iris pattern, if you see there are certain uveitic entity. For example, all of you read in Western textbook, it is heterochromic iridocyclitis, Fuchs heterochromic iridocyclitis. But in Indian patients, the heterochromia is very difficult to notice. It is so subtle that you may miss that. So for that, you have to look at the iris pattern, how the pattern of the iris is, and based on that, if there is blurring of the crypts, the fine pattern is lost, then only you can diagnose that. So similarly, the iris nodule, you can see here the first picture. It's not picture. The first picture, you can see it is in dilated state, and you can't appreciate the iris nodules, the Kopis nodules. Whereas the same photograph, same patient in undilated state, you can see you can appreciate the Kopis nodule. Now, coming to a case, anterior uveitis, a 26-year-old, history of recurrent attacks of redness, ocular pain, and blurring of vision in left eye. Now, how will you proceed? Now, if you try to decode that, you take a meticulous history and try to apply the Woods classification. And here you can find out that the codes take you are sure that it is an anterior uveitis, and then try to see that what is the laterality of that inflammation, and is there any specific clinical signs. Now you know that it is already a recurrent attack, and it is unilateral because only left eye is involved. Now you see here again what is happening. So now, when we are talking about the recurrent and unilateral, then the three causes are very important. One is HLA-B27 associated uveitis, one is Fuchs uveitis, and one is viral uveitis. Now see how we can decode this. Now HLA-B27 associated is alternating bilateral. That means the patient will come to you and will give a history that yes, there is history of recurrent attack of redness, but sometimes it will come to right eye and sometimes it will come to left eye. So we call it that ping pong uveitis. It will go to one eye and then again it will jump to other eye. So that's why it is bilateral. And the inflammatory material, if you examine, there will be fibrinous exudate. Now coming to the next variety is the Fuchs uveitis. Now Fuchs uveitis is almost always unilateral, but yes, there are certain cases it can be bilateral also. So as a rule, it is unilateral, and you have to look that carefully the iris pattern. If there is, you can see here the blurring of the iris crypt. So these are the diagnostic actually features of the Fuchs uveitis. And also another, the typical keratic precipitates, that the stellate capes. So stellate capes can be seen in Fuchs uveitis. Another important point you have to understand about that is that you know that all the keratic precipitates are arranged in a base down triangle, which is known as Earl's triangle. So there are two entities where the Fuchs, the keratic precipitate will cross the midline, and it will involve the entire corneal endothelium diffusely. So there are two causes. One is your Fuchs uveitis, second is the viral uveitis. So now when we are decoding the viral uveitis, what all you have to see? You have to pay attention to the corneal signs, try to see the corneal sensation in exam. This is very important because sometimes the examiner may ask you that have you checked the corneal sensation. The second is that you have to see the corneal oppositives, whether there is any corneal edema or Decimet's folds are there. And obviously all of you know that the viral uveitis is notorious to have a secondary rise of intraocular pressure also. So you can see that. Now coming to that keratoprecipitate, I told that the fuchs and viral uveitis will have diffuse distribution of keratic precipitate. Now another thing you see is that the pigmented keratic precipitate. So it is very characteristic of the viral uveitis, and also sometimes they may have a mutton fat KPs also. So these are the point in favor of this. And the second thing is that the iris atrophy. If you see here, the two things you can notice in viral uveitis. One is you can see that without any dilatation drop, you can see the shape of the pupil. Sometimes it is called D-shaped pupil. Why it happens? Because there is destruction of the pupillary raft by the viral viruses. And also sometimes you can see the patchy iris pattern here, as you can see here. This happens because the viruses, particularly the herpetic viruses, they causes the endarteritis and causing the necrotic patches in the iris atrophy. Now, sometimes you can see a corneal opacity and you can tell us the diagnosis, like in this case, you can see here the coin-shaped opacity. So this is very common in CMV retinitis. You can see the coin-shaped corneal opacity and you can see the pigmented KP. So this can be seen in cytomegalovirus anterior uveitis. Now, always you have to remember one thing, that dilated fundus examination is must in all cases of anterior uveitis. For example, you see this patient with anterior uveitis, and if you do the direct ophthalmoscopy, as many of you are only examining the patient with direct ophthalmoscopy, and if you see, this is the view you'll get. But if you dilate this patient and try to examine the periphery with a indirect, you can see that this is this. So this was not a case of anterior uveitis. What was that? Anyone? Any postgraduates? This is acute retinal necrosis. So the acute retinal necrosis you can miss if you are not examining the periphery, and if you only try to decode it only by your slit lamp examination, you will diagnose it as an anterior uveitis. So the indirect ophthalmoscopy is must. The second thing, for example, here, a 30-year-old male with diminution of vision, and there is a history of fever 10 days back. Can you tell me your diagnosis? Anyone? What kind of uveitis is this? So as a postgraduate, it's very important that you have to differentiate between the retinitis and choroiditis. So I'll just make it little simple for you. There are a lot of colors and morphology, but remember one thing, always try to trace the retinal vessels. It will lead to diagnosis. Because if you see here, what happens here, in cases of choroiditis, the lesion is here and the blood vessel is here. So is here, you can see the choroiditis lesion and you can see the blood vessels here. So if you can see this kind of picture, then it is choroiditis. And similarly, if you can't see the blood vessels like here obscured, you can see here the retinitis lesion is here and your blood vessel is here. So then it is a case of retinitis. Clear? So now, second thing you have to remember when you are dealing with a case of retinitis is almost always infectious. So only two conditions you will remember where the retinitis can be there and it is not infectious. Number one is Behçet disease, where you can see this kind of retinal pigment, retinal infiltrates. So in Behçet disease, what you have to take history? You have to take the history of genital ulcer and oral ulcer if you see this kind of infiltrates. The second is if you see this kind of cream colored multifocal subretinal pigments and in an elderly patient, then you have to suspect the diagnosis of intraocular lymphoma. So what you have to do, elderly patients, you have to do a CNS imaging, you may have to do a vitreous biopsy to take the sample for cytology and mutation, and you have to consult a ocular oncologist. Now, how to evaluate a case of retinitis? The common three scenario in our clinical practice is: number one, viral etiology; second, it can be syphilis; and third, it can be toxoplasma also. There are several causes of viral retinitis. I'm not going into detail. Just to give an idea about suspect syphilis, if you see this kind of ground glass appearance. Now, what is ground glass appearance? You can see here. This is you can see the small creamy white superficial retinal precipitates. But here you can see this is called the ground glass appearance because you can see the underlying retina. Okay. So now in contrast to that, if you see that, sorry. Yeah. So in contrast to that herpetic retinitis, the herpetic retinitis, it will be, I'll just take 5 minutes and run. So herpetic retinitis, it will be fully ossified retina, whereas in syphilitic retinitis, you can see the underlying. So now coming as a postgraduate, this table is very important, like how to differentiate between HSV, VZV and CMV. So CMV primarily is seen in immunocompromised patients, and if you see the mode of transmission, CMV occurs through the blood. It is mainly the vasocentric lesions you can see, whereas in HSV, VZV, it starts from the periphery, a pattern that corresponds to the termini of the ganglion cells of the nerve fiber layer. And the HSV and VZV replicates very fast. If you are not starting the treatment, it will finish off the entire retina in maybe in three to 4 days. Whereas the CMV, the replication rate is very slow, and it will take a longer time to involve the fundus. Now, suspect ARN, already I have showed you. Now, this is coming to little bit about the choroiditis. When you are looking for the choroiditis, you have to understand that there are two variety you need to know. One is serpiginous choroiditis, one is serpiginous-like choroiditis. Now, what is serpiginous-like choroiditis? You can see that geographical patch-like pattern here, and you need to treat to differentiate between these two. Serpiginous-like choroiditis means that the secondary pathology is infection. For example, in India, the most common cause is tuberculosis, whereas the serpiginous choroiditis, the classic serpiginous choroiditis is autoimmune, and the classic treatment is through the immunosuppressive and pulse corticosteroid. Then multiple choroidal tubercles you can see in various like tuberculosis and sarcoidosis. And then Dehlen-Fuchs nodules, you have to see there may be various nodules in the periphery of the fundus. And always you remember, when you think about laboratory investigation, there are certain conditions, there is no need to order any investigations. Without laboratory investigation, you can diagnose. The one is that infectious etiology like acute retinal necrosis, CMV and toxoplasma. You see the clinical phenotype of the lesions and you can make a diagnosis. For example, I'll give you a picture. Do you need any laboratory test to diagnose it? No, you can clearly tell that it is a toxoplasma retinochoroiditis. So similarly, sometimes you have to pay attention to some clinical signs, like there is a healed lesion where adjacent to the lesions there is a active retinochoroiditis, then you can make out. Then sometimes you can see this kind of pattern, like these are called Chirelis arteritis. So these are very common in toxoplasma. So coming to the retinal vasculitis, you have to differentiate that the certain retinal vasculitis predominantly involves the vein, like sarcoidosis, toxoplasmosis, Eales disease and HIV. And you have to suspect the tubercular retinal vasculitis if you see this kind of retinochoroidal chorioretinal patches around the blood vessels, then it is a characteristic sign of the tubercular retinal vasculitis. So just I'll finish with this slide. So any postgraduate, can you decode here? I am just showing you jigsaw puzzle with two clinical disease, clinical entity. Can you tell me the two diseases? Yes, louder. Yeah. Vikage, correct. Another? Behçet. So see, now if you go into that, so you correctly diagnosed it a Vikage and it's a Behçet's, right? Now I'll tell you the secret behind that, how you diagnose. I have shown you 3 ophthalmic signs and I have given you 5 systemic signs. But still you are an ophthalmologist, you could diagnose that. So that means that you have to pay attention to the systemic signs. Sometimes you can decode your diagnosis just looking at the systemic signs also. So always try to do that. To conclude, you have to remember that how to present a case of uveitis in examination. The number 1 is you have to diagnose the anatomical site of inflammation. Next, you have to find out whether it's a bilateral or unilateral. Number C, whether the course is chronic or acute, and you have to document. Now, when I talk about the documentation, that is very important for the post-graduation. Let's see how to do that. For example, I'm showing you these slides. This is very important in examination. If you are documenting a case of uveitis, remember one thing: you have to mention about the hypopyon. Even if there is no hypopyon, you have to mention that there is no hypopyon. This is mandatory to diagnose a case of anterior uveitis. And also, if you are documenting the hypopion, you have to write the height of the hypopion, that how much it is, 1 millimeter or 1.5 millimeter. So that is mandatory. So again, coming to that iris nodules, you have to mention this exactly where it is mentioned. So similarly, just last slide of this. Yes, just last slide of this you have to document it properly. The clock hour you have to mention where the retinitis lesion is, where exactly the retinal vessel is involved, and you have to follow the color coding for that. Thank you.
Thank you, Dr. Partho, for your nice presentation in details. Like, I have one question. In your clinic, what is your, are you seeing more syphilitic patients, syphilitic uveitis patient nowadays? Vis-a-vis
Yeah,
few years
definitely.
back,
Syphilis is very common nowadays, and the problem is that we were taught that you should always take history of high risk behavior and all, and I think we have gone beyond that. So any patient, the Sun classification now says that any uveitis you are seeing, ideally you should rule out syphilis. There is no question of high risk behavior or going into asking the patient about that and then ordering syphilis. If you are examining a case of any kind of posterior uveitis, even the scleritis also, it is mandatory to rule out syphilis in these cases.
Thank you.